thank you for joining us. Um, my name's Dr. Stephen Barabas. I run VBS Medical, and we do certain high-end rehab and pain management equipment, along with some podiatry stuff. And we're also tonight joined by George Cummins, who is founder of Gait and Motion. And yeah, we've worked together on a number of different things. But the first time we've gone and done a project together where we're able to go and do a webinar together. And this is the first of two that we'll be doing. We've got another one which will be joined by actual active clinicians working in January. So hopefully, if you like this one, you will be able to join us for the one in the new year. George, is there anything you would like to say?
Thank you for inviting me, Stephen, to I guess collaborate on the webinar. I can already see in the I guess the attendee list today, there's several Footscan users already that are joining here. I know, Stephen, a lot of your Kaylee's community are in here as well. So I've tried to pitch this to cater for all. I don't want to tell everyone that's already got the system everything they already know. So hopefully everyone will be able to take home something new from today. And those of you that aren't in our Gait and Motion Clinics network, haven't used pressure measurement before, hopefully there'll be lots of things you can pick up and perhaps give some thought for future clinical practice. But yeah, no, I'm happy to get going whenever you're ready, Stephen.
I'll just speak to everyone just to let you know, and for George's benefit as well. At the moment, we have 58% of the audience are podiatrists, chiropodists, and another 4% are foot healthcare professionals. 7% are doctors, doctor or nurse. 7% are physiotherapists. Another 7% are laser clinicians, and 19%, interesting, as something else. So I don't know where that fits. It'd be interesting on the chat box what something else accounts for. Of the people in the audience, 33%, you'll not be surprised to know, are using some sort of gait analysis equipment, and another now 36% are using some sort of foot scanning device. 43% are using a class 4 laser. And another 14% are using another form of laser. So both you and I are well represented. 29% are using shockwave, which again ties in with a lot of podiatrists out there. 4% are using some sort of TENS or electrical stimulation. 4% are using electrical acupuncture, and 14% are using no equipment whatsoever. Of that, not surprisingly, the 15% are not applicable for the next question in regards of what you use it for. But of the ones who do have something, 33% are using it for creation of orthotics. 70% are using it for musculoskeletal rehabilitation. 59% are using their equipment for pain management, and 30% are using it for wound care. And then there is some aesthetic and some laser acupuncture use as well. So it's a pretty broad spectrum, but not surprisingly, orthotics and pain management and musculoskeletal feature highly along the wound care. Okay. Anyway, thank you for filling that in. I will now mute myself, and I'll let George lead the show here, and then I'll do my little presentation afterwards. So thank you, George.
Thanks, Stephen. Okay, good evening all. Having a look at the list, as I say, I know a lot of you I've spoken to before from a Footscan user perspective. Nice to see a lot of names of people from, as I say, the K-laser side of things as well that I haven't spoken to before. So nice to virtually meet you. As Stephen mentioned, obviously we're two completely separate companies. Stephen was kind enough to support our national conference for the past 2 years at the NEC as one of our trade partners. And when we got speaking, it was clear we had quite a lot of mutual clients or clinical partners, both using Footscan and K-laser. So just to expand on that conversation, really, we thought obviously there's a lot of crossover in terms of an assessment tool and a treatment modality, and perhaps it made sense to do something a little bit different from a webinar point of view, and try and merge the two together and see how they can work in conjunction for clinical practice. So hopefully everyone will take something from this evening's session. From my side, I'm going to give an introduction to Footscan technology, which is our industry-leading pressure measurement system. very quickly about myself. I am co-founder and director of Gait and Motion Technology. We founded in 2018, and we have quite a broad spectrum of biomechanical and MSK measurement solutions, from handheld digital goniometers and dynamometers, all the way through to fully integrated gait labs at the top end, to include force plates, EMG, motion capture, etc. We are most known in the clinical world for our Footscan technology and the integrated FITS 3D printed orthotics, which I will touch on this evening as well. I'm also co-founder of Gait and Motion Clinics, which is our national community of clinical practices who have all invested in our Footscan technology and offer FITS 3D printed orthoses to the general public. We've grown from 0 to 530 private clinics over the past 7.5 years, and that continues to grow week by week. And we're really looking to continue developing foot and lower limb care across the nation, making it more accessible to all and making it objective and data-driven for optimal outcomes. So my half of the session today, I'm going to touch on why some clinicians use orthoses, and I appreciate not everyone on this call orthoses is going to be relevant. I know we've got a couple of doctors on here as well, but just going to give an introduction to how we can utilize Footscan technology to optimize that. I'm going to delve into what plantar pressure measurement is and how that can be utilized in the assessment process, both in a static and dynamic way, and we'll explore 2D and 3D options in that measurement. Quite a key area of crossover with K-laser is the diabetic foot implications. Of course, K-laser is a fantastic tool for wound healing. So there's certainly some crossover there from a measurement and retest perspective. And then I'm going to talk about the data-driven parameters that pressure measurement provides us and how we can utilize that to optimize our orthotic prescriptions. So kicking off, why foot orthoses? There'll be a high percentage of you on this call that already prescribe orthoses in some shape or form, which could be ready to wear off the shelf, could be semi-bespoke, could be bespoke. And of course, there's vast arrays of bespoke devices these days, from traditional through to more modern modalities. If we really strip them back, we're looking to optimize foot and lower limb function and improve stability. And one of the key things that we look to introduce orthoses for is to offset and redistribute excessive forces or plantar pressure. And without technology, that's something that we can, really struggle to do because we can't measure it. But tools like Footscan enable us to measure the plantar surface of the foot at very high speed, so we can really fine-tune our devices. We can cut out specific areas, we can offload certain structures as well. We also look to provide comfort and impact protection. Certain materials are extremely powerful at impact protection. One that we use quite commonly is a material called D3O, particularly in our athletic population, or runners, etc., but also in the diabetic world as well. Of course, we look to relieve foot and lower limb complaints and potentially improve postural alignment. And another big area of foot orthoses these days is reducing injury risk. We can never say that we can prevent injury altogether, because of course that can always happen. It could be a contact injury as such. But of course we can optimize foot function to reduce that risk. And that's a real growing area, particularly in that athletic and sporting population, but actually important for everyone. From an orthoses point of view, I saw an interesting debate or question I was tagged in a podiatry forum actually earlier this week, discussing about bespoke devices and prefab devices. And I think it's quite clear that there is no one-size-fits-all approach when it comes to feet. We're all very different in our foot structure, how they're developed over time and how we move. But we all have different anatomical and biomechanical differences. You see here an individual foot scan on the right-hand side of the screen, a left and right foot functioning very different dynamically. We have a left foot quite excessively overloading the first MTPJ, whereas we have a right side with quite a rigid forefoot there. It's not really loading that first MTPJ at all. So, if we gave that individual the exact same device on both sides, is that the optimal solution for them? The answer that we probably know is no. So making devices bespoke to that individual's needs, particularly when they're presenting with some sort of pathology or pain, is obviously going to be a really important thing to think about. And research has shown that bespoke devices can reduce peak pressure by up to 35% versus a prefab off-the-shelf device. Orthoses aren't anything new. They have been around for many years. And of course, as with everything, like our mobile phones, our TVs, they've hugely developed over time. And I would say more so in the last 5 years than the last 30 years. And traditional methodologies back in the day, it all started from a sort of casting perspective. So plaster of Paris to get that static foot shape. We then delved into foam impression boxes. And in more recent years, the world seems to be transitioning into a more of a digital 3D scanning approach. But of course, people still use all three. They have certain preferences, and it's not for us to say what's right or wrong or what's best. But these are some of the static ways to assess a patient's foot. Dynamic foot analysis brings in elements of technology, such as pressure measurement. And of course, our Footscan system, something that many of you will already be aware of, is a real key driver in the dynamic foot scan analysis to understand how that patient's foot moves from ground contact all the way through to propulsion. Got lots of bones, muscles, ligaments in the foot, all working together to enable us to propel forwards and to really get as much information as possible about what's going on beneath that foot can only be a good thing. Another interesting post I saw, I think it was earlier this week actually, from a lady called Jo Lucas, who is a very, very experienced orthotist. And she's had a foot scan system for, I would say, probably a decade now. She was really indicating the importance of not just looking at the static foot, because as I emphasized, the foot changes hugely when we move. So if we're looking to optimize foot function, we really want to understand, well, where are the pressures and forces when we move? So actually taking that data in conjunction with the 3D shape of the foot is extremely powerful. We're able to bring all of that together now to really optimize our decision making and really get the best results for patients. But I thought I'd just pop that slide in here as well from an external sort of third-party opinion. Steve mentioned at the start there's quite a high percentage of individuals that haven't used pressure measurement before. So for those of you that haven't, ultimately the systems, they start 0.5 meter all the way up to 2 meters, and they are packed with small pressure sensors that effectively record data hundreds of times every second, and we can go up to 500 hertz, so 500 frames a second. It's typically recommended to be a minimum of 200 for movement analysis. There are plates out there that do 50 hertz or 100 hertz, but we really want as much data as possible beneath the foot when we're moving, especially at faster speeds, just so we can be as accurate as possible with our diagnosis. We tend to measure it these days in kilopascals or newtons per centimetre squared. And there's quite a simple conversion between the two there. But ultimately, it gives us information that the eye cannot see. As much as people say, I don't need technology, I can just use my eyes, you can't see what goes on beneath the foot. And well, you specifically can't be entirely accurate about that. And when we come around to retesting further down the line, you see hundreds, if not thousands of patients over the years. So, remembering what they were like previously is, of course, a challenge. And a big area that we quite heavily involved is with the orthotic design as well. So enabling us to have the objective data to help us make our decisions about that orthotic intervention. And there's a few sporting examples there on the right-hand side of individuals utilising our Footscan technology. There is a common debate, particularly in the podiatry community, about 2D or 3D scanning and what's best. Now, ultimately, 2D scanning is like foot scan pressure measurement. We understand how that patient's foot moves across a pressure plate. We can understand what goes on as that individual moves. And I'm going to expand onto some of the data that we can gain from a pressure measurement system. But we get that individual walking back and forth multiple times across the plate. We capture an average of, we say a minimum of 6, but more the merrier, in terms of foot contacts. And all of that data can be looked at as individual steps to look at variability, but we actually also average all of that data when we go through into the orthotic design. That enables us to look at what goes on at heel strike, at mid-stance, at propulsion, and everything between. This is one of many screens in our dynamic analysis. It's called 2D, but ultimately it shows us how the dynamic center of pressure moves through that patient's foot from ground contact all the way through to propulsion. So we can look at things like timings, directions, where the pressure is going. And again, I'm going to expand on this very shortly, but that's what 2D foot scanning looks like. 3D foot scanning is capturing a 3D anatomic shape of a patient's foot. Now, historically, we have and still have quite big, bulky scanners that you can utilize that someone can stand on. They're not so portable. Of course, they're slightly more expensive. But in recent years, we introduced the materialized SAM 3D scanning app, which is made for iPhone and iPad. But we can now 3D scan a patient's foot for free. It's included free of charge for all of our foot scan users. And it's a really quick and easy way to capture that geometric foot shape. So when it then translates directly from the phone into our software, we can look at things like the foot length, the width, the arch height, the arch length. And that's a 3D foot scan. But a 3D foot scan doesn't tell us anything about how that patient's foot moves. It's a shape. And again, if you had a non-weight bearing versus a weight bearing 3D scan, that shape's going to be slightly different. So that's why we've always been very focused on the dynamic assessment. But actually, what is now what I would consider the gold standard is that 4D approach, combining the 3D scan geometrically, anatomically, with the dynamic pressure data, giving us the best of both worlds in dynamic foot analysis. Not only is that a really fantastic way of bringing it together for the clinician's perspective and understanding, it's a really powerful visual for patients. They can see what's going on beneath the foot, and seeing is believing. If you can see what's going on and where your excessive loading is going, I think that really helps with patient buy-in as well to really understand what you are saying as a clinician, because the general public are not clinicians. If we're not assessing them and showing them information and visual data, their understanding can be often quite a challenge, and that can really then hinder their sort of, I guess, confidence to proceed with treatment and come in and be retested. I'm going to expand on objective pressure data analysis and what we can really gain from this, some of the things we tend to look for, and then how we can translate that into treatment modalities. And of course, that's not always orthoses. We're certainly not saying that everyone needs for orthoses, but they can play a really fundamental part of the day-to-day life for a large proportion of the population, both from a rehab perspective, but again, also from a preventative role. So that first screen, the dynamic 2D, one of the main things that we look at is the center of pressure, otherwise known as the COP progression. And that image you can see in the middle of the screen is a fairly good example of a normative textbook dynamic center of pressure. Hopefully you can see my mouse, but when we walk, the center of pressure should start at the lateral bore of the heel, and we should have a medial roll. That should then cross the pink line as the foot supinates during mid-stance, cross the pink line again as the foot pronates prior to propulsion, and then pushing off or toeing off between the first and second toes. So we're looking for that to be a nice, smooth, symmetrical roll between left and right. You'll also see along the white line, hopefully, little white dots. And these are placed down at set time intervals. And what we're looking for is a nice even spread of those white dots along the white line, as you can see in this image. But in some patients, they might have a rapid transition from heel strike through to forefoot, and they'll have the dots really spread out because they've had a rapid transition. Oppositely, you might have a patient where they've got lots of white dots bunched up under the second metatarsal head. That means they're spending a lot more time on that area. Time is quite significant when it comes to plantar pressure measurement. And when we combine that with the actual pressure load, pressure over time becomes even more important, something that I'm going to expand on. It also accurately enables us to look at the timing, or the ground contact time, otherwise known as the stance phase of the gait cycle. When walking, typically we're looking for that to be between 600 and 800 milliseconds. I've picked a random case file here that shows some asymmetry just to expand on some of these concepts. And you can see for this individual, slightly slower in their walking, above that 800 milliseconds, slightly favouring the left side in terms of ground contact time, but within what we would really consider a normative asymmetry of 50 milliseconds between left and right. And we can synchronize this and we can play it through side by side at up to 1/100th of the speed. So if someone had a rapid transition to forefoot strike on the right side, we can sync it, we can play it through, and we can pick that up extremely easily. If we were just eyeballing the patient, we wouldn't really be able to do that. We certainly wouldn't be able to communicate that in a measurable way to the patient. The foot axis is the pink line that splits the foot right down the middle, from the middle of the calcaneus through to between the second and third metatarsal head. A normative foot axis is typically 5 to 15 degrees of external rotation. Now you can see in this particular scan here, the left foot is slightly internally rotated, the right foot is slightly externally rotated. And we utilize this pink line as a reference point for that dynamic center of pressure. We don't want the dynamic center of pressure to shoot right down the midline. That's not what this is for. It's literally cutting the foot in half. We also have a 3D analysis within the Footscan visual data as well. This shows us the peak plantar pressure data, again from ground contact all the way through to propulsion. We can look at it as a frozen still image like so, or again, we can play it through. And it's again, a really nice visual way to look at foot function. We can quite clearly see areas of peak pressure. They'll really spike out, as you can see, for this individual on their fifth metatarsal head on the right side, and perhaps their big toe on the left side. But again, it's not always about, wow, that's a lot of pressure. This individual is actually offloading their first metatarsal altogether. Now, it could be for various reasons someone does that. It could be structurally. It could be that actually they've got a pain there and they're just trying to, take load off of it. Hence why they're loading more through the lateral border. But again, we don't purely assume based on data. We need to have that conversation with the patient to understand their pain. It's not a case of just walk a patient across Footscan and there's your answer. This is to complement every clinician and not to replace them. Impulse is a really key measure in Footscan. It's pressure over time. And in the diabetic population, this is really significant. A high impulse is associated with an increased risk of ulceration due to a prolonged pressure over time. So again, this is actually a go-to screen, and that is one area in particular where us and K-Laser have quite a lot of crossover in our clinical base as well. I always say to any clinician that invests in technology, or whatever that may be, don't get too overwhelmed by graphs and numbers. It's great to have them, but you could spend 2 hours with a patient if you really wanted to, and we don't have that luxury of time. But often I think if you do go a little bit more in depth with patients, if there's quite a significant thing that they're experiencing, you can really hit home on it and show them a huge asymmetry between left and right, or a huge overload in a particular area. Because in every half meter of a Footscan pressure plate, we have over 4,000 sensors. They're really small, so we can be very specific in terms of where we're looking at pressure over time. And this will automatically map 10 landmarks of the foot, which is the big toe, lesser toes, metatarsal heads, midfoot, medial and lateral heel. So for example, on this patient here, I've popped a couple of blue arrows on there. You can see a huge spike of pressure through that fourth MTPJ on the right, really not using the first at all. But actually we should see the highest pressure through the first, then the second, then the third, and the fourth, then the fifth. I'm not going to read all of this out, but there are some reference peak pressure ranges for these sort of 10 key areas of the foot, and I split it into that rear foot, midfoot, forefoot, and toes, just to break it down a little bit more. So yeah, if someone wants to do a little bit more reading in this particular area, by all means take a picture of the screen. Yeah, just some sort of key pressure ranges there. Just to note as well, that pressure range is in kilopascals, and again, there is a calculation. 1 kilopascal is 0.1 newtons per centimeter squared. You can switch between your preferred unit in the settings of a Footscan software. I think most people in our network use newtons per centimeter squared. Also got to bear in mind, what's normative for me is not normative for everyone else on this call. We're all different in our age, body weight, foot structure. We might have neuropathy, and we might have different walking speeds, and that will also all play a part in this information. So these are really reference ranges. Not everyone's always going to be normal. The goal really is to get them pain-free and functioning well. One of the key aspects of our Footscan analysis is the zone screen. Now, this will, again, split the foot into 10 anatomical zones, and it will take all of the pressure sensors from those zones. You can look at this as individual steps, but you can also average all of the footsteps. And that's why we say to capture multiple. It's going to give us a better representation of one step, because inevitably there is variation from step to step. I often find it quite useful to actually look at everyone's individual steps. Is there a pattern? Are they doing the similar thing every time? Maybe they're overloading a specific area every time. And if that's quite clear, often I'll highlight that. But actually, on the flip side, every footstep could be totally different. The average, of course, is useful in that respect, but what it also highlights is quite inconsistent movement. Maybe they've got poor stability, maybe they're in pain, so again, something perhaps to think about. This will also, in black and white, give them a foot type based on the foot contact surface of the forefoot, midfoot, and rear foot. So based on data, you could actually show someone if they're flat-footed or high arches based on how that foot's loading dynamically. And that's not always what you think as well. Some people are surprised when they're at conferences when they say, oh, can I have an assessment? What actually is going on beneath their feet when they move? And again, I won't read these out, but we've got some normative timings for those areas of the foot. So I broke this down into the rear foot and the forefoot in particular. This is a reference from Ian Sadler, who spoke at our national conference last year. But one thing here again that I briefly touched on earlier is the loading of the metatarsal head. So the optimal start, so percentage being 0 initial ground contact, 100 toe off. So, you know, the fifth metatarsal should engage first, then the fourth, then the third, then the second, then the first. And that's not always the case. And we've also got the optimal start and end positions. So of course, as that foot rolls through, we've got the 4 stages of that foot roll: heel strike, pre-mid stance, mid stance, and propulsion, in terms of at what stage in the foot roll that should begin and at what stage that will finish. So toe off, of course, being 100%. Again, don't get too bogged down by numbers. I've really put these in for existing Footscan users, maybe to give them something a little bit more advanced to think about, that they might not have looked this in depth before. We do also have a risk analysis feature within Footscan technology, which is an interesting one. I think it is most powerful in a screening environment. So, for example, there are Premier League football teams that will screen every player on the first day of pre-season to look at a injury prevention perspective. Is player X more predisposed to problems than player Z? The British military is another good example. They've been utilising Footscan for over 20 years. There's a whole page on our website about the Armed Forces Footscan research and how they've utilised that to aid their footwear design over the years. If anyone's interested in having a little look, I popped a little link at the bottom. Now, this looks at the medial to lateral forces in the rear foot, midfoot, and forefoot, considers things like peak pressure, timing, stability, to quantify that level of risk. Now, it's not going to diagnose, of course. It's not going to say person A is going to end up with Achilles tendonitis. But based on that patient's loading and the forces through their feet, like a traffic light system, it just gives you something to have a look at and think, well, maybe why is that flagging up? And we find that quite useful. I would say in a clinical environment, though, when you've got patients coming in that already have an issue or pain, I don't get too caught up with risk analysis. They're here for a reason. We need to assess what's going on, perhaps why that's being caused, and what we can do to help them. But certainly in a screening world, really useful. I do quite a bit of work in the elite sport world, from runners to golf. And again, in that world, it's quite useful to almost categorize certain individuals into certain areas. And if someone is flagging up as high risk, perhaps you have a more detailed biomechanical assessment to see what's going on and how it can potentially keep them pain-free. Touching on that diabetic foot implications, I've lifted some stats here from Nicola Shearman, who's one of our Gait in Motion Clinics partners. She's got a podiatry clinic down in Worcester. She did a webinar for us specifically on Footscan for diabetic foot screening recently. And just to bring back some of those fairly powerful stats that, 11 people in the UK have diabetes, 10% will have an ulcer, and 80% of them become amputations. When you really think about it, that is shocking. But actually, the whole sort of, I guess, NHS model at the moment is quite reactive rather than proactive. Of course, they're very overwhelmed, budgets are tight, which of course we all appreciate. But if we had clinical specialists all over the country that could offer annual diabetic foot screening to prevent an issue, or, you know, offload things quicker, let's say. It's often someone ends up in that vicious cycle when it's too late. We're fighting fires, the toe's been cut off, now they're overloading through here. That could have been prevented by quick action, and that's something that is quite rapidly spreading across our national network. I'd say there's probably over 100 podiatry clinics now utilising Footscan for an annual diabetic screen, marketing that. I'm really going to make a difference over the years to come, I have no doubt. On the right-hand side here, very quick video of Nicola's diabetic foot screen. Of course, it's not just pressure measurement. She'll be looking at her Doppler for pulses, doing sensation tests, etc. All the things you'd expect, but also then capturing that 3D scan and pressure data. And I know she's had some fantastic results with patients in that sort of caseload in recent years. But something really important to think about, because as I mentioned, the impulse. So one of the things about diabetes, and I think Stephen probably is going to touch on this when talking about K-laser, but it causes an increase sort of a peripheral neuropathy, reducing the foot sensation. So people haven't quite got the same sensitivity in the foot, which thus then can increase that ulceration risk. From a pressure point of view, load above 60 newtons per centimetre squared or 60 kPa is strongly correlated with ulcer development. But again, we don't want to just look at that number. How much time are they spending on it? And that's why I've really put it in bold, the importance of measuring impulse. And again, studies have shown pressure-based orthoses, so ones that have actually taken pressure into consideration in the manufacturing process, have reduced ulcer recurrence by 71% over 12 months. I've done a little screen recording here. You'll see that little white dot moving through the foot. Now watch here how that rapidly moves through the midfoot and really stops on the first metatarsal head. So we've got a rapid transition for this patient from ground contact through to mid-stance, and a real slowing down of that movement when it gets to the forefoot. Not only is there a slowing down of the movement, we've got an extremely high pressure going through that point. And if you see just next to that on the right-hand side is that patient's visual impulse. So a real glowing red hotspot, and something we would certainly look at, particularly in a diabetic patient, to try and offload, redistribute and prevent. One of the really powerful things about any technology, but particularly Footscan, is the ability to measure outcomes. Now this could be day one, someone's come in with an ACL injury, they're really unstable, they're in pain, they've followed a strength training program, and naturally over time they've had some healing as well, and we've retested. You'd like to expect to see some improvements in gait. But a particular area for this as well is the annual diabetic foot screen. We could assess someone once a year, maybe once every 6 months. We could have someone's history for a decade. That makes it measurable. That enables us to jump in and intervene if something does change. And sometimes things do get worse in that respect. And it's at that moment that you've been able to, I guess, nip it in the bud before it's got too bad. You can intervene. And of course, if it ever gets too far gone from a diabetic point of view, there's of course that NHS referral for that more sort of specialised care. But measurable outcomes, I would say, one of the most important things in private clinical practice. We are taking people's money to assess them and give them a treatment. If we're not measuring it, we are guessing in some respect. And my personal belief is the patient deserves that, at the very least, to be assessed, given some data, and then we've got a data-driven care. I think that's really important. And that's not when it just comes to feet either as well. It could be range of motion, it could be strength, but their issue should be measured. So again, any technology, Footscan in particular, what this is really bringing, and a bit of a cheesy tagline, but a subjective art into objective science. We are all in a clinical profession here. It is science-based. People are coming in for your clinical expertise, and as I say, they're paying for that. So it's giving us that real-time repeatable measurements. And Footscan isn't just used for gait, we utilize it for balance assessments, whether it's single leg, 2 legs. We can use footwear as well, so we can look at footwear implications, pre and post orthoses, different devices. We can look at functional movements like calf raises, sit to stand. So it is a very versatile assessment tool in that respect. So it's not just podiatrists that are using this for orthotics. There's lots of physios that are using it for upper body tasks as well. So yeah, it's called Footscan, but it's a tool to provide accurate data. As I mentioned, from an orthotic perspective, it's giving us that evidence-based design, and it's giving us justifiable interventions. So we're not just flogging someone orthotics because we think they'd benefit. We're assessing them to see, would they benefit? And then we're showing them why. So it's really enhancing the patient communication and trust. And I think when people have a assessment these days that is like this, they're super impressed. They'll tell their friends, their family, and from a private practice perspective, that only leads to people speaking good of you and referring people to you. And as we all know, word of mouth is the best way to grow your practice. Moving on to the last segment of my half of this webinar, how can we use this data to inform a prescription control? So if we have come to the conclusion that we think orthoses are going to be beneficial as a next step, what can we do with this? We need to consider the patient's footwear choice. A lot of patients will wear footwear that's horrendous for them, too tight, the wrong size, and sometimes it just can't be told. Of course, we always want to try and recommend the very best. So if we're going to go down an orthotic route, we want to make sure the device has enough space in it. And if we're, working with a sporty person or a runner, it needs to be a neutral shoe. We can't be putting data-driven orthoses in a immediately loaded or immediately posted shoe, because we're actually then going to overdo it. So we need to go into a neutral footwear. But, some ladies will like to wear their dress shoes when they go out in the evenings, and there's not a great deal of space in them. But we're able to cater for all types of footwear for that individual's needs. So, it's quite common for clinicians to prescribe 2 or even 3 different styles for a patient. Also, perhaps for sporting needs sometimes. Our orthoses are called FITS, P-H-I-T-S. We moved away from traditional manufacturing 8 years ago purely to 3D print for various reasons. Repeatability, accuracy, you get exactly what you order. All things actually as a clinician you want, right? But where FITS really, separates itself from other 3D printed devices on the market is that they are data driven. So various aspects of the device are calculated on the information that's been captured. You're not locked into these decisions. These are things that you can amend and tweak, but it's giving you data-informed prescriptive elements. So things like top cover thickness and density, based on that individual's weight and forces through the feet. That will be a suggestion. Navicular support, so the level of control in that medial arch, localized stiffness. I'm going to expand on all of these little aspects a bit more visually for you, because it's quite hard to just look at a picture of an insole and appreciate this. So obviously we've assessed the patient, we've done a static, dynamic assessment and a 3D scan. The system will suggest the thickness, hardness and material of that top cover. Now you can add in other heel paddings if you wish. You can increase the shore density if you want a more dense top cover. You can reduce it if you want it to be a bit softer. But that is a starting point for a device. One of the key things that 3D printing has really accelerated away from traditional devices is local stiffness. The fact that you can have some areas of a device rigid and others completely flexible is so powerful. In a company that I worked at in the past, all of the devices were polypropylene, plastic, or carbon, supposedly. And you effectively get a 3D shape of the patient's foot, and it's the same density throughout the shell, whether that's the lateral border, the medial arch, the heel. You just don't have the same level of control with polyprop, carbon, or even EVA, to be honest with you. So a FITS device has various zones in here, and again, based on the data, it will suggest rigidity in some areas and flexibility in others. So this individual here, whose right side are quite excessively loading that right lateral forefoot, You can see they've got a stiffer or more rigid lateral border and actually slightly more flex in the medial aspect of the arch on that right-hand side, just to give a little bit more flex and encourage that load through the first MTPJ. Again, these are suggestions. Some people have a misconception that you just walk someone across the plate, click order, and that's your insole. That is absolutely not what this is. This is to give you a data-driven foundation of a device to build upon. You have complete control, more than you would know if you're not using the system already. So we can have varying widths of the rear foot, midfoot, and forefoot, and we can scale that as we wish. We can also sit the 3D scan of the patient's foot on top of the device. I'm going to touch on that a bit more very shortly. And as we start to work through the prescription from rear foot, midfoot to forefoot, again, some of these parameters are taking that dynamic information. One of the most common modifications or design parameters in orthoses is rear foot posting, where we raise up that medial or lateral aspect of a heel. And a very quick example, this patient here, if we look at the pink line is the medial heel, the blue line is the lateral heel. A rear foot post comes into play in the first 15% of a foot roll. And again, I'll refer to the percentage as 0 initial ground contact, 100% toe off. So I'm really focusing on that first 15% for rear foot control. Ideally, we're looking for the pink and blue lines to be fairly tight together, fairly close, equal forces. That's kind of what we're looking for a nice stable rear foot at ground contact. And we can see for this individual, I've lifted their automated data. It's suggesting a neutral rear foot post bilaterally. Again, if you wanted to as a clinician, you can add that in as you wish, but that's a suggestion based on the data. From a different perspective, this patient here, the first 15% on the left foot, again, pretty sound, nice and tight together. But on the right side, it really does start to drift. And by that 15%, you can see they've got considerably more load through the medial heel than the lateral. And that pulls through directly into their design. You can see the left side suggested neutral, the right side has suggested a 2-degree medial rear foot post. And again, that can go up and down either way based on data, but also your clinical judgment. Navicular support is the level of control in the medial arch, and that will vastly vary from extremely flat feet to extremely high arches. And you can see here 6 different Footscan 2D screenshots from someone with an extremely flat foot all the way through. And this one here that my mouse is on, number 4, is kind of what we'd consider that sort of normal sort of foot type from a pressure perspective. Now, of course, we can't necessarily change someone's foot structure or arch height as such, because we're born like it often. And again, from conversations I've had with people that have inquired and asked about orthoses, it is clear that across the industry there's very varied knowledge in prescription orthoses, and quite a common theme is a lack of confidence in prescribing. I've had people say, I've got a patient with a really flat foot, do I need to put a big high arch in it? Well, no, actually, that will cause problems. Actually, you'll see here on a scale of high to flat, what we're really doing is bringing that ground up to the foot ultimately. We don't want to overdo it. But again, this is something that is calculated based on the information that we've captured. So it might be a difference of 0.5 millimeter between left and right, but again, that is based on the individual's data. From a medial arch point of view, again, there's been an age-old debate of 2D versus 3D, and you can't do this from a scan. Well, you can if you also place your 3D scan on top of it, because you can completely manipulate where you want that navicular support. You could bring the apex up, down, back or forth as you wish. And again, getting the best of both worlds in terms of that dynamic 2D data and also that 3D scan data. And with all of the other aspects of the device, it's like your traditional prescription, right? You have total control over it. So from a heel correction point of view, maybe you are prescribing for an elderly patient that's quite unstable and you wanted a deep heel cut. Maybe a football player, you want a really low heel cut because they haven't got much room. You can do that. Maybe they've got a leg length discrepancy and you want to apply heel raise. Maybe they've got Achilles tendonitis bilaterally and you want to put it on both sides. You can do that. And as you'll see on the screen now, as you're making these changes, you're seeing a 3D orthotic render in front of you. And I say to all of our clinical partners, think of yourself as the architect in this respect. You're no longer just eyeballing a patient and ticking boxes on a prescription form, sending it to a lab and hoping it comes back like you've asked for. Turns out that isn't always the case. What leaves your laptop, your PC, is exactly what you're going to get, to the nearest 0.1 of a millimeter. And you can see it and rotate it in full 360. So it's really giving a clinician confidence that they're going to get what they order every time. And, you know, I'm sure some of you in podiatry forums might have seen posts this week with frustrations of not getting what they order or being out of stock for various things, which is, of course, frustrating, not just for clinicians, but for patients as well. Metatarsal corrections, very common things like a metatarsal dome or a met pad, a go-to for things like a Morton's neuroma, also very useful for offsetting and redistributing pressure in the central forefoot. If we select these, it will put it in a clinically sound position based on that information, but we can also move it based on where that pressure is to really fine-tune. Maybe wanting to add in metatarsal cutouts or ray cutouts. Again, you can simply add those in a device and optimize them as you wish, and you can look at it in full 360. One of the things that certain people mention when we talk about 3D printed orthotics is, what if I get it wrong? Do I have to print it again? Well, with some types of 3D print, yeah, you do, unfortunately. But with selective laser sintering or SLS orthoses like so, they're thermoformable. So they can be heated, they can be remolded slightly, and then they'll reset. So I always say less is more with certain orthotic modifications anyway. But if your patient couldn't tolerate the height of the met pad, for instance, we can simply heat it from the bottom, lower it, and reset. That's something that we can do for clinicians, or they can try it themselves if they really fancy it. But it's not a case of tough, do it again. There's a lot you can do with a 3D printed device. So something just to be aware of. And lastly, at the forefoot, one of the really nice reasons for capturing the pressure data is we can overlay that directly on the shell from above. So if we're looking to optimize forefoot loading, like so, this individual here, maybe, and I'm not saying this is, a fact for everyone, but maybe we wanted a first metatarsal extension on the left side to assist with hallux rigidus. Maybe on the right side, we wanted effectively a first metatarsal cutout just to raise or pitch the lateral forefoot and encourage the foot to roll through that first metatarsal head that's not really being loaded so much. We can scale it back side to side based on not only the individual's foot shape, but also where that pressure loading is going. So again, be as really specific as possible for that individual. Last element of the prescription I'm going to touch on, I don't want to take over Stephen's time anymore, it is the offloading aspect. If the patient had bony prominences or fibromas and we wanted to put in an offload, we can specifically place them on the shell. We can change the width, the length, the rotation, and the depth to really make that as fine-tuned to that patient as possible, which is quite a nice feature, again, especially if you're going to sit the 3D scan on top. And you can see it just like so. Patient experience in the modern day in private practice is extremely important. What is going to distinguish you from the other clinician down the road or in the next town? And it's how you treat them throughout that journey. The assessment, the feedback, the follow-up, and the report. So capturing all of that information is great, but how do they get it? Well, as soon as you click order, they actually get a report bespoke to them. You can brand it up with all of your clinic colors and images as you wish. But what this will have in their report, and this will be digital in their inbox, it will have wearing in guidelines for orthoses, their average dynamic data, their 3D scan anatomical measurements, and any prescriptive elements that you've also incorporated will be visualized in 3D with a layman's term of what that is or why it's perhaps been incorporated. And of course, you can make some additional notes as well. But that is a next level follow-up rather than just saying, pop your foot in this box, we'll get you a pair of insoles in a month, and we'll see you then. So we're really trying to engage the patient in this process as much as possible, because we know that that also improves their buy-in and their confidence to persist with it too. That is an introduction to Footscan technology. There is a lot more that we can do with Footscan from a assessment and rehabilitation point of view, but I just thought I'd give you an introduction, hopefully expand on some of the knowledge of existing users. And for those of you that I haven't spoke to before, if that sounds interesting and something you'd perhaps like to explore for your practice, you can find my team at 3 conferences this month. We'll be down in Windsor later this week for the BCA, the Royal College of Podiatry conference in Glasgow, and also Therapy Expo in Birmingham. So please come and say hello to the team. Alternatively, please feel free to reach out to me and I'll be more than happy to have an initial chat with you. Stephen, I will let you take over from there. Hopefully I haven't sent you to sleep.
No, I'm still alive, and
That's good.
my pulse is there. So
Good,
yeah,
excellent.
all good. Thank you, George, for giving a very in-depth overview about the importance of going and doing data. I completely concur that I think from my background, obviously, I mean, in the clinic I have, we try to do everything. So you can do blood analysis, you can do everything. And I think the more data you have, the better you have taking that patient through the journey, but also the more accuracy you have in treating them, whether it's through orthotics or through other means that you need to do to go and get that person as healthy as they possibly can be. So yeah, thank you for that. And thanks for an oversight into it. So the next part really is just about VBS Medical and how some of our technology definitely provides the rehab side to what some of the orthotics and the gait analysis allows you to be able to use, and then hopefully improve whether it's an acute or a chronic injury. So the main focus of what I'm going to be doing is on laser, and it will do both the musculoskeletal and the pain management. And I've put in 2 slides about some of our diabetic sides that we work with as well. But we do cover a range of things. So VBS Medical, I have a veterinary company called VBS Direct, and we work in the veterinary sector, equine, dogs, cats, and exotics. But in the human side, we work across 3 areas. We do the podiatry side, we do MSK pain management, and we do aesthetics and beauty therapy. But the commonality is that we use medical devices which are called MDR, which is medical device regulation. So they are all at a higher standard than almost anything else in those categories, because we have to prove not only the safety, which everyone has CE marks on their devices, but we also have to show that our data is on our machines to go and validate what we claim they're able to do. So this gives it a slight different take on what we usually are talking about. In this picture, you can see the K-laser cube on the left. You can see our other range, which is Indiba, which is radio frequency, and then you can see the K-laser blue with a variety of different heads. Both K-lasers are very portable, and some of the Indiba products are portable. We'll go through briefly this because I think at least 60% of the audience aren't using any lasers. So I apologize for those who are already using class 4 lasers, but you'll see the symmetry and how this can fit in with the gait and motion analysis Footscan. And we will also cover some of the podiatric aspects beyond just standard wound care and MSK rehabilitation. Critical words in this, which is also our nemesis, is the word laser, because everyone seems to have a laser. And that also means that a lot of clients coming in, when you tell them they are offered K-laser, may already say, oh, we had that and it didn't work. And that's because the bar for actually producing a medical laser is very low. And there is no other companies that have this MDR rating. Laser stands for light amplification of stimulation of emission of radiation. And it's a very specific way of creating light. And our laser for doing wounds can be relatively low level. But for doing deep musculoskeletal and especially some of the podiatric treatments, it's a high intensity laser. So it will do from low to high to allow you to be able to do what we call photobiostimulation of both skin and deeper musculoskeletal and even spinal and bone structures. We work similar to Gait and Motion across a very broad spectrum. In ours, we probably do an even bigger thing, going and working within the universities and the dental hospitals and aesthetic clinics. But for today, we're really talking about those top four areas where we are working within clinicians and sports therapists. You can see the portability of the machine just by the size of it next to a human. And you can see the range of clinical usage from geriatric homes and rehabilitation post-surgery to dental to podiatry to musculoskeletal to elite sports. And there is no doubt the earlier you use a good therapeutic laser, the minimal amount of scarring you get. So like Gait and Motion, we work with some pretty impressive Olympics and sporting franchises, and they're using it much, much more proactively than the average clinic in the high street. And that's no disrespect to the high street. It's just these are very motivated patients who are desperate to make sure that they are competing at the highest level and not getting injured. And therefore, we can use it very proactively. Also, the good bit about lasers is you can use it from a baby all the way through to a centurion. And it has a very broad spectrum in its clinical applications and use. So from a clinical perspective, these are critical things that a good therapeutic laser should be doing, and definitely K-laser does. We target chromophores, specific molecules in the body, to increase metabolic activity, to open capillary beds and lymphatic drainage, which allows it to improve not only the oxygenated, healthy nutrition, but also gets rid of the waste and also the catabolic molecules, which are heightening pain sensation and also preventing anabolic processes. In doing this, we have a direct anti-inflammatory effect, but also when targeting central nervous systems, we can also have an analgesic or a motor stimulatory effect on damaged nerves within the spine. Overall, with this improved metabolism, with this better vascularization, lymphatic drainage, we will repair and enhance the cell growth. And in also stimulating the immune system, we are not as directly anti-fibrotic as shockwave is, and therefore it can work very well against with shockwave. But we are able to stimulate the immune system to reduce the fibrotic tissue through immunoregulation, and therefore we can get less scarring. We're just in the process of publishing a paper from Chelmsford Burns Unit, which is the biggest burns in the UK and Ireland, and where we've had a very great success on reducing scars and infection on 60 to 80% burns wounds. Also, we can do acupuncture, and I saw someone in the audience is using acupuncture. And it is a very successful way of stimulating acupuncture and then also having a photobiostimulatory effect. We are not an LED. We're not some sort of big marketing about red light therapy. This is a serious medical device that uses coherent laser light and is able to penetrate deep within the body system, but also superficially, and do it in a short treatment time. So we're a powerful laser. We have both class 3B and class 4. This is the amount of power emitted per second in watts. And therefore, when we're doing just skin, we generally have a low powered laser. And when we're doing deeper structures and pain management, we can become a class 4 laser. And we can also, in the podiatric world and the aesthetic world, we can become a little surgical laser as well, for doing things like onychomycosis and ingrowing toenail surgeries and verrucas. The most powerful thing to talk about is power density. People go, "Oh my God, you're going to burn someone." Well, no, they don't understand how our laser is operating. It can work at a lower power in order to stimulate wounds and have a broad, low power density, or it can have an intense high power density, and it is able to go and do toenail, ingrowing toenail matrix ablations, and allow patients to have a very short downtime from what usually would have been a painful phenolization. Here again, you can just see the differences. So when we are over 1,000 watts per centimeter squared, we start to have more of a surgical photoablative effect. Where around 10 watts per centimeter squared, we've got more of a biostimulatory photochemical effect. So we can use the same laser for doing two very different purposes. Most of you tonight will just be interested in the photobiostimulatory effect. And this shows akin to photosynthesis, where we can target molecules which have certain pigmentation in the body. And in doing that, we can then improve circulation, oxygenation, and cell metabolism. We're working in the cube lasers, in the red and the infrared spectrum, which are non-ionizing, and in the aesthetic and some podiatry lasers, we can also have an additional blue laser, which allows you a more accuracy surgery. These are the key molecules that we're targeting: water, melanin, cytochrome C, which is copper in the mitochondria, and iron in the hemoglobin. And those are the key molecules that we target through 4 different wavelengths. And this illustrates how this operates. So in our laser, we have a 470 nanometer beam, which is one of the highest absorptions for water. And even in an arthritic joint or in a static wound, we can improve vascularization and blood flow to it, which obviously brings good nutrient, oxygen-rich blood to the area, but also then starts to take away carbon dioxide, lactic acid, and all of the inflammatory markers, which may be inhibiting healing and also going and heightening pain sensation. We can then use a 905 beam, which targets iron in the hemoglobin, and we can trick the oxygen to dump even in non-respiring or non-actively respiring tissues. And now we have all of the nutrients, we have the oxygen. We can then raise metabolism by targeting the mitochondria, the ATP production within these cells. And in doing that, whether it's a chondrocyte or a tenocyte or a keratinocyte, we can then boost the levels of ATP production through using in the skin a 660 beam, red, low power. And in deeper tissues, we use an 800, which can penetrate deep into the tissues and deliver stimulation for mitochondria way within bones, tendons, and muscle cells. A certain amount, our nemesis is skin, so trying to get past skin is difficult. There will be scatter, and only a percentage will be transmitted. But of that, if you are only doing superficial or chronic wounds, you only need a relatively low level of energy measured in joules per centimeter squared. But the deeper you go into the tissues and the more chronic and painful the condition is, the higher the levels of energy are required in order to change that biologically. And therefore, you need to start with a lot of energy externally if you want to go and have short treatment times that fit into our busy schedules. Weaker class 3B and some weak class 4 lasers deliver not a lot of energy over a time frame, and therefore you are able to hold them over one place. This is more akin to laser acupuncture, and allows you to stimulate trigger points and acupuncture points, but it doesn't per se very much photobiostimulate deep tissues. I mean, using a class 4 laser, yes, you can use it at lower power for superficial, but then you can also go and target deeper tissues and have a photo biostimulatory effect at much deeper tissues in a shorter time by delivering a lot more energy at depth in a shorter time frame. Here you can see you can either do manually, where you've got this probe and a fiber optic that links to the machine where the laser is being produced, not in the handle, but in the machine. Or you can have a hands-free, almost like a shower head, which you can position over a patient, both of which are equally effective. Critically, we don't compromise on the wavelengths. We think 4 wavelengths, and some of our machines now have 6 wavelengths, are the best. But most of us don't have a lot of time, and therefore, in order to deliver enough energy in a short time frame, you need a lot more power at depth. But if you're doing a large wound, you cannot have high power, and therefore you do need more time. So sometimes doing wounds is longer than doing deep musculoskeletal with our tissue, with our laser. And finally, anyone who's seen a K laser knows that it will go through multiple phases automatically when you target a foot ankle injury or a knee injury or a back injury. And this is because different cell lines have different absorption for different pulsing of light. And in doing this, you are able then to target and optimize the growth of cells, not just by targeting their mitochondria, but by also allowing them to have the opportunities of growing and multiplying more rapidly. And here you can see leukocytes, osteoblasts, endothelial cells, and smooth muscle. The higher the frequency, the more soft tissue orientated it is. We don't have like a non-steroidal or a steroid, a direct anti-inflammatory. It's indirect because we're creating a much healthier environment through better blood flow and better lymphatic drainage. So we get rid of the waste products that are inhibiting growth and cell metabolism, and we're getting rid of the catabolic things which are causing pain sensation. So we're helping that, and hence we can help even spinal nerves by just making it a much healthier environment to allow proper cell neural function. Okay, some clinical papers here to show how we can help. One of the critical things here is blood flow. And we did a study on physiotherapists at university. They were 20-year-old young, healthy students. We used plethysmography to measure their blood flow in their forearm. And we did it over 4 days because there were 4 different groups that were rotated. Placebo group, a 1 watt, a 3 watt, and a 6 watt average group. Over the course of this 4 days, it was clear that using higher power created a much greater change in blood flow to the forearm, which then had the knock-on effect of providing oxygenated nutritional blood to soft tissue ligaments, muscles, tendons, cartilage, of which the authors said was one of the greatest contributions to soft tissue healing. It was dose dependent, and although you cannot infinitely keep going up in power, it did show in this study that 6 watts was more effective at getting long-term blood flow than 3 watts, and 3 watts was better than 1 watt. So the higher the level of average power was better for soft tissue. We've worked since 2017 within the NHS, 2015 actually, and this article was published in 2017, where we worked on diabetic feet. We've shown at Guy's and Thomas's, and then shown publications that we can heal 80% of non-healing diabetic ulcers, therefore preventing foot amputations. And then, as you can see from George's lecture, this can work extremely well when monitoring and using orthotics in combination, using the Gait scan, Footscan technology. We found out that unless we lasered the whole lower leg before the wound itself, we didn't get enough lymphatic and venous drainage and new blood flow to the foot to allow that and optimize that healing of the wound itself. So it is a 2-phase process of treating the lower leg first, with high levels of energy to get blood flow and lymphatic drainage, and then treating the wound itself with high frequency, lower power settings to get the wound itself to heal. This study at Guy's and Thomas's looked at non-healing ulcers of 3-year duration. There was a control group which had the same treatment of silver dressings, maggots, and sterile maggots, and also multiple debridements and antibiotics and other topical dressings. The only other aspect was the other group added in K-laser twice a week for the course of 6 weeks. And over these treatments, we found that we healed 80% of these non-healing ulcers on average in 4.6 weeks, when none of the placebo group healed. This was published in Diabetic Care. And since that, this year, we published a paper on venous ulcers from work in another NHS cohort down in Eastbourne. So we've got other work that's happening at the moment. I know this isn't feet, but I use this as an example of how repeat treatments are important. So this group of patients did use a low power or lower power laser. Hence, they were coming 5 times a week for 2 weeks, so 10 sessions. They were treating carpal tunnel, and there was a laser group versus a placebo group. And after 2 weeks, the grip scores, the prehension scores, none of these were statistically significant, even though numerically they looked better. They stopped lasering for 2 weeks. So the placebo had 4 weeks of no laser, and the laser group had 2 weeks laser, 2 weeks non-laser. And by the end of 4 weeks, this now was statistically significantly enhanced. So these patients continued to improve despite not lasering. So that initial period of 2 weeks provoked a biological change to improve their healing potential compared to the placebo. And when you looked at the VAS scores, even after 2 weeks, you were beginning to see changes, which continued to happen post non-laser treatment. So that's an interesting one to see. There are good studies on high power lasers looking for Achilles tendinopathies. This using eccentric exercises and a placebo laser versus eccentric exercises and laser therapy using an 820. 12 sessions over 6 weeks, and like you and I, recreational Achilles tendinopathy issues. These patients were monitored over that at 4, 8, and 12 weeks, and you can see there was a very significant difference at each of those markers, which you can see graphically here on the VAS score of pain. The lower triangular line is the reduction using laser. And you can also see the improvements in stiffness in the morning and dorsiflexion, all of which are positive outcomes through adding in good, powerful laser therapy. Similarly, using 10 watts per centimeter squared, an 830 beam, twice a week for 4 weeks. These are arthritic knees, and you can see, yes, there is a placebo effect, so the gray does reduce, but the laser group reduces by 71% greater, which continues over 2 weeks. And the fourth range of bars on the left-hand side and on the right-hand side show that after finishing laser for a month, there was a slight increase in the parameters and a slight reduction in the range of motion. So what we're saying here, we're not going to cure osteoarthritis, but we can manage it a lot better. So the patient is much more pain-free and much better able to exercise and go about their lives normally. But it will require repeat treatments, whether that's once a week or twice a week or once a month, in order to maintain a good status quo. We've done work in regards of musculoskeletal and neuromuscular junctions. And here you can see some studies looking at disc surgery, and in average, these patients were up on their feet 5 days earlier when they were given laser therapy on their spinal disc area compared to the other group. We've been able to show that we can stimulate neurogenesis and reduce cell apoptosis in the spine. And we've also done studies on the human, the horse, the rat and the rabbit to show that we can penetrate deep in the brain as well, in order to stimulate neural tissue. From a plantar fasciitis point of view, this study looking at 25 individuals, it isn't using our laser, but it does show using a very similar beam to what we have. We have a 905, 3 times a week treatments for 6 weeks. There were no ultrasonographic changes, but there was a very significant improvement in VAS daytime scores. Similarly, when comparing a high power versus a low power laser, again, using different wavelengths here, you 70 people 3 times a week over 3 weeks. They had orthotics, they had stretching exercises. They looked at a whole load of different scores. They didn't have gait analysis, I'm afraid, George, but they did a lot of other things. Over that period of time, both groups improved compared to the baseline, but the high level was significantly better than the low level laser. And this was shown on these scores, looking at functional pain, functional symptoms, different sporting exercises and quality of life. And on the right-hand one, you're looking at the statistical difference in the lower figure compared to the baseline when they started, and very high, significant improvements. Although I do not have a study looking where we've looked in orthotics and K-laser, this does tie in a little bit with what George was talking about with diabetics. So diabetics, obviously you get the ulcers, venous ulcers as well you can get, which sadly in a high proportion will end up with amputation and eventual death. In this study, though, what we're looking at is peripheral neuropathic pain. Now, again, in diabetics, you can get neuropathic pain. This group and cohort we looked at actually were not diabetics. They were women who, unfortunately, due to chemotherapy and radiotherapy, they survived uterine and ovarian and cervical cancer, but it did leave them with a very significant chronic peripheral neuropathic pain. So we use K-laser, lower dose, about 7 watts average on their feet and ankles, and averaging 12 watts, peaking at about 20 watts on their lower back. We gave them a whacking dose of about 10,000 joules, and we did not induce cancer, despite being a photobiostimulator. We did not cause any complications, but we had a very effective low toxicity treatment of this neuropathic pain. And this was a double-blind crossover study. Obviously, we didn't do any histological analysis, but they surmised that this has to be because we improve the cells and prevent cell apoptosis. This is a little study just to show the podiatrists of what K-laser can do. So you can see the whole range of things. Here you can see now the same laser, we can use a high power head targeting verrucas, which I was treating today. And we can go and remove that verruca and create an immune response. And over the course of 2 or 3 sessions, we get rid of about 80% of those verrucas, 85%. We're not using local anesthetic here. Again here, having treated using that high power head, the onychomycosis, we can then use a therapy head over the toe. And a bit like Glanuna, we can then stimulate the immune system, and we can get better blood flow to go and reduce that. We can target diabetic ulcers, and using laser over the ulcer itself, but then as you saw from the work we did at Guy's and Thomas's, treating the whole lower leg to get better lymphatic drainage and blood flow. And there are different heads you can use across all of that. And then finally, come on. You can treat things like Morton's neuromas, which is definitely a complicated aspect and a very painful condition. And we were able to reduce that, similar to working on tenosynovitis and other problems in the hand. We can, in this case, target the nerves and reduce some of the swelling. And here you can see that stand where you can position it over the feet and allow the patient to sit there, and allows you to do other things as well. Okay. This just shows you treating the onychomycosis. And obviously paring back the toenails beforehand in order to get the desired effect. Here you can see some of the one of the patients in that trial we did was his own control. So one foot we treated, and within 3 sessions we had healed a non-healing ulcer. And then on the other foot there was an ulcer. Sorry, we didn't show that there. Here you can again see treating a very large verruca, and the patient is quite happily chatting away as we are making a little bit of a hole in his foot. And again, you saw this earlier, doing a small cone tip. We're able to go and ablate the back of the matrix, and literally a day later, there is no swelling, there is no phenolization damage to the surrounding tissues. And I've had patients who've gone skiing a day later, having not been able to walk on their foot the day before. Okay, this is a little overview of the nail matrix surgery. Some of you may know Kieran Canny. He definitely is a big endorser of the Gait analysis, the foot scan. This was pretty early on in Kieran's treatment of these. He helped us produce a very nice publication of 10 individuals that we monitored over 12 months to make sure there was no matrix regrowth. And you can see, similar to the phenolization, you would use tourniquet. It's a nice sterile procedure, and you're able then, with almost no blood whatsoever, to be able to go and get rid of that matrix. This is some of the data from him and some of the pictures following up through. Here's the results from it. Since this, we've probably had in the UK about 200 patients being treated to date. They're all their little foot medic clinics across the UK. And these are just some of the numbers, whether it is Gait analysis or K laser, you really need to do your figures to work out when you're going to get a return on investment. But definitely within podiatry clinic, this is a very profitable piece of equipment to be able to use because of the range of clinical usage that it is able to do. And it's nice to see it from a fellow colleague. Okay, so overall, it's easy, it's profitable, it has no consumables, so you once what you get is what you pay for. There's no hidden costs. Insurance covers it, no problem. We will train you and make sure that you are competent using it. And we will provide all the marketing and all the support, and we'll have ongoing support through WhatsApp groups and other webinars like tonight to make sure that you continue to learn and grow. And that's really a summary of where we are. very broad spectrum, very useful piece of tool for MSK, pain management, and podiatry. And at the very top end of what laser therapy can do within this medical knowledge as we know so far. And those are our different pieces of aspects. And as you can see, it's short treatment time, so they fit in very nicely into the clinic, and they fit in very well within a modern day forward-looking podiatry or MSK pain management center. Thank you.
If anyone has any questions specific for Stephen or myself, feel free to get in touch with us after this evening.
Yeah,
Um,
but hopefully you saw the synergies of the two products, and you can see how in a forward-looking practice that you can monetize it, but also accurately get good data, and treat appropriately with all the great things that you already have within your arsenal. And these two things can definitely go and contribute and improve the quality of care that you provide.
Perfect. Well, Stephen, thanks again for having me involved this evening. And yeah, I will no doubt catch up with you again very soon.
Very good. Thank you, sir.
All
Thank
right.
you,
All the
everyone, for
best.
joining.
Thank you.
Bye.